basically we go through some background knowledge of what we know at the moment. If you have read the data from the National Health and Mobility Survey 2011, you would notice that our contraceptive rate among our women 15 to 49 years of age is only 54.5%. And what does that mean? We're not doing so well. Because if you talk about the unmet need for contraception, where if you are fertile, reproductive age, does not want to be pregnant, but sexually active, you're supposed to be using contraceptives. The problem is only half of us are doing that, and half of us are not. And that's when you have this large group of women with the unmet need for contraceptives. We should realize that we have not done so well, because in the last 2 decades, the rate has remained the same. So is it the patient, is it us, or is it the system? What do you think? As with everything, it's multifactorial, right? But we play a big role in there. So when you do your postpartum rounds, or postnatal rounds, you remind them that please try not to come back next year, or in 2 years' time. This week I had a 32-year-old who's a gravida 9. And I said, do you really plan to do this? Having the 9th pregnancy at 32 years of age, which sounds like such a heavy job to do. She's obese, she has a lot of, she's obese, but otherwise she's perfectly alright. HB was 14, and that is actually a big surprise considering that she's grand multiparous. She said, I'm okay, because my intention is to have as many children as possible by the age of 30. So actually she did that. And I said, what about this one? You're 32 now, you're past 30. Last one. Because she enjoys getting pregnant. No complication whatsoever, no diabetes, no hypertension, no anemia, spontaneous labor, perfect vaginal birth, no PPH. So what can we say about that? So that's the tricky bit, okay? But at the same time, it is our duty to remind them of contraceptives, okay? So talking about the golden age, so who are the golden girls? How many of us here are in this category of the golden girls? Come on, girls. Don't be shy. Nice, right? You're more valuable when your weight in gold. Okay, so that is normally referred to as when you are 40 or above. But for the maternal fetal people, 35 is when you start to get anxious already, because the risk starts to go up after 35, okay? And up to 55. Why are the organizer putting this as a topic in their conference? So there must be some significance, right? When you're over 40. How many of you have heard from a patient who are pregnant when they are 40-something that they say, oh, I thought I'm already 40-something, I should not get pregnant anymore. I didn't expect to get pregnant. So I said, are you sexually active? Yes. Have you been using contraceptive? No. And you expect not to get pregnant? How? I said, oh, okay, yeah, betul juga. So basically, because they thought they're not very fertile anymore, and therefore they're not really bothered to use contraceptive, and that has led to unintended pregnancies. And for us doctors, our concern is the older you are, the higher your risk. That is why if you see a patient who's 40 and above and who are pregnant, your first response would be alamak, okay? Because you know you'll be looking out for a lot of risks and complications. Okay, so these are the special considerations when you want to advise them about contraceptives. You'll be different from those the young ones, okay? First and foremost is patient safety. What is the safest for you? Okay, because there are health risks when you're over 40. And if you're over 40, how many of you would consider getting pregnant again? Probably the number is very low. And therefore they would prefer either a longer term or a permanent form of contraceptives. Basically, in this discussion this morning, I'll be going through just the principle and the guidelines and not so much the detail, okay? And if you want to prescribe contraceptive, you would also want to ask if they're having menopausal symptom, and you can consider that in your choice of contraceptives. So if you're having menopausal symptom, probably barrier method is not going to help you in that sense, and you want to use something that can give you contraceptive plus some relief of the menopausal symptoms. And the good thing is they have lower rates of failure because their fecundity rate is lower. Less frequent sexual intercourse. This may be contentious. We are assuming the older you are, the less number of coitus you have. But I suppose we will listen to Prof in the evening and see whether that's really true or just a myth. And older women are supposed to have higher compliance rate because they are more motivated and they understand if you get pregnant, the risk is high. So that's a good bit of it. Okay. These are all the choices that we have, and if you critically look at this, you will know there are some that you would have a lot of concern in using for older women. But take note that non-hormonal contraceptives are safe regardless of age. That is about safety. Are they most efficacious? For example, if it is a barrier method, if you are older, you're going to be bothered getting up to go and take it from the drawer, the condoms. So probably not the most effective if you're going to use that. But as far as safety profile is concerned, non-hormonal is the safest. I'm making an assumption that all of us are very familiar with medical eligibility criteria from WHO. This is still, while there are a lot of other criteria, this is still a good and a simple way of making an assessment. I would normally tell the student, go and read all the 187 pages of it. But if you're too lazy or don't have much time, just read the executive summary, 2 pages. Okay, so basically you're categorized as 1, 2, 3, 4, whether you're eligible to use this or not. If you're in category, if the contraceptive is in category 1 for you, means go ahead, use it. If you're in category 2, you can still go ahead and use it, but you have to be a little bit, practice a bit of caution because there's some risk to it. But overall, benefit still outweighs the risk, meaning use it. Category 3 is when the risk outweighs the benefit, unless pregnancy carries higher risk than the contraceptive. Okay? Category 4 means don't even think of it. You cannot use it. So there is such thing called limited clinical judgment and clinical judgment. So just 1 or 2, go ahead and use. 3 and 4, don't use. In regards to age, if you look at age alone and other factors are the same, if you use combined hormonal contraceptive by age group, if you are less than 40 years, use without restriction based on age alone. If you are more than 40 years, you can generally use based on age alone, but if you have some other added condition, it's not category 2 anymore. Basically what it says is, you're less than 40, you're very well, go ahead and use CHC. If you're more than 40, better get a doctor to have a look at it, to make a risk assessment, because after everything said and done, patient safety is paramount. Okay, so what is the big deal about getting older? So these are the risks, okay, and these are the particular things that we're going to look at: arterial disease, venous disease, and cancers that can be influenced by the hormonal state. Okay, simple, right? Okay, in looking at arterial disease, so basically this is what this is about, trying to remind you that older people have certain health risks, and these are the specific risks that we are talking about. In regards to myocardial infarct and stroke, if you are younger, the incidence is very low. It's very rare to see younger women in reproductive age having myocardial infarct and stroke. But with the changing in the landscape of epidemiological part of health, this may soon not be true anymore. Okay, but for now, if you are young, your risk is low. If you are older, risk is higher. If you have CHC, if you are young, the risk is not increased. But the older you get, and if you have an arterial vascular disease, then your risk becomes high. Okay, what we're talking about is smoking. How many of us smoke? Cigarette smoke, not the sauna kind of smoke. Second-hand smoker, then the number increase, right? Third-hand smoker. So just because we don't smoke does not mean we are not exposed. If you are hypertensive, diabetic, dyslipidemic, obese, older. So the more factor you have, the higher your risk becomes. If you have migraine headache with aura, that has been identified as an independent risk factor for ischemic stroke. So CHC in people with all these risks, 3 or 4, don't use it. Okay? But this is talking about combined contraceptive. Progesterone only, there are no restrictions because it is not estrogen. All these factors, arterial disease, most of the concerns are with estrogen use. So basically, if you want to use your Depo, the LNG IUS, you're alright, not a problem. Okay. This is to give a little bit more detail. Smoking more than 15, smoking less than 15, category 3, category 4. It doesn't matter, right? You're not going to use. But if you're going for exams and they're asking for more detail, number of cigarette has some value, but practically in real life practice, it doesn't matter. You're already category 3 and 4, which means consider other methods, okay, and not CHC. Okay, so that was the arterial disease. In regards to venous disease, the older you get, the higher the risk. Actually, it's not so nice getting older in that sense, right? Because your health risk increases. But the only thing you can do about that, you can't stop age, and therefore your risk is increased. What you can do is try to minimize or mitigate by keeping all the other factors normal. So if you look at the risk, if you are using CHC, you're in the golden age, your incidence is 100 per 100,000. When you were very young, your incidence was 4 times lower. That is what, 25 minutes? Normally the sound is more hostile than that. So, and if you are older and obese, then you double it. Okay? But even then, pregnancy risks are higher. So the risk of dying or getting thromboembolism in pregnancy, if you're pregnant, is still higher than getting thromboembolism from the medication. So that's the balance that you have to do. So the recommendation, if you are over 40, in regards to venous thromboembolism, you may want to be cautious about it. Category 2 means further evaluate the risk. It does not mean just go ahead and use, or it does not mean don't use. It means further evaluate the risk. But if you're over 40 and you have this history, unexplained or pregnancy related, do not use. If you have varicose veins, it's not the same as venous thrombosis, it's category 1. Varicose veins are probably a badge of honor. You have done that much in your life and you get the varicose. No problem. Okay, breast cancer is always something that, breast cancer is a battle that we have not won. We are still losing big time to breast cancer. And that's why the discussion come up all the time. As you get older, your risk of breast cancer is increased. So if you ladies are between this age, then you are 1 in 200. If you ladies are here and it is increased, okay, 1 in 69. And if you're like me, this is the risk. So age alone will increase your risk, okay? I think basically because the denominator is now reduced, therefore, statistically the risk is higher, okay? So if you want to use oral contraceptive or combined contraceptive, you want to look at your breast cancer risk. Nothing very much that you can do about age. Look at the family history. If you have family history of breast cancer or you have previous benign breast disease, does that limit your use of combined contraceptive or even progesterone only? It does not. So unless, of course, if you have a gene mutation, but that's a different discussion altogether, okay? But in comparison to arterial disease and venous disease, which are mostly estrogen related, breast cancer are both estrogen progesterone related. So if you have current breast cancer or past breast cancer, then we would not like you to use CHC or even progesterone only, because you know about the estrogen receptor and progesterone receptor in the breast cancer. So category 3, largely do not use any hormonal if you are current sufferer of breast cancer or you have it in the past. If that's only in the family, you can use it. Okay. Also, if you are above 40, there are other considerations. For example, you may have abnormal menstrual bleed that can be treated with your contraceptive. So just take one medication and you can treat 2, or it can satisfy 2 conditions. You're starting to lose your bone density, you may have vasomotor symptom, and you have all the cancer risks as you get older. So you can see here, if you use a combined hormonal contraceptive, it can reduce your heavy menstrual bleed, it can reduce your rate of bone loss, treat your vasomotor symptom, and reduce your risk of ovarian, endometrial, and possibly colorectal. At the end of this, we're going to have a quiz, and if you win, you can see Dr. Rizwan for the prize. LNG IUS, you know, you can reduce heavy menstrual loss. If you, I used to say that, and after that they really went to the organizing committee chair and asked for the prize. It was supposed to be a joke. If you use Depo, it can help with heavy menstrual bleed. But if you have prescribed Depo to patients, you will know that some of them are not happy because your periods become prolonged, irregular, although it is very light. So it can reduce heavy menstrual bleed, but you have to tell them it's not going to be a perfect period of 28 days interval. It may be a bit confusing, but it is not heavy definitely. And progesterone in the MPA can relieve vasomotor symptoms, and it can reduce the risk of endometrial ovarian. Condom, if you are over 40 and promiscuous, you will still want to use condom for protection of infection. Okay. Rizwan and I shared a patient who's really promiscuous, and we had to counsel on the appropriate contraceptive. How in a way she's monogamous, or not quite, but she likes to have it 7 to 10 times a day. So we think there's a lot of risk involved here. So this would probably needed in the patient to prevent sexually transmissible infection, apart from pregnancy risk. She was over 40 at that time. Yeah. And if you are like some of us are done with the whole thing and we want to just sterilize it, that will reduce your ovarian cancer risk, because the current opinion is a lot of breast cancers arise from the tube. So if you disconnect the connection between the tube and ovary, the ovarian cancer risk is reduced. So if you have done this, we should be happy because one of our cancer risk is reduced. Right. Okay, next question is when to stop. The patient will ask you, lama sangat dah ambil ni, bila boleh berhenti, right? Especially if you're already in your late 40s and 50s. So basically, if you go by whether you're using hormonal or non-hormonal. If you do not use, if you use a non-hormonal, you will know when your period stops, right? So if it stops after 2 years, sorry, if you are amenorrheic for at least 2 years and you are less than 50, your menopause can stop. If you're over 50, 1 year of amenorrhea is enough to make a diagnosis of menopause. If you're not sure, send for the bloods. Okay. If you use progestin only or progestogen only, if you are very new in this and you are confused with progestin and progestogen, progestin are normally used by the American papers, progestogen by the British-based papers. It's the same. Okay, it's a artificial progesterone. So if you use progestogen only, you can continue up to age 55. And it gives you the benefit of relief of vasomotor symptoms. If you're already after 50, it's the same. Okay, so we take 55 years. Why? Why are we use 55 years as the cut-off value? How many percent of you should be menopause by 55? It was there in the earlier slide. If you are not hyperglycemic from your nasi lemak. 96. Okay, but you have to be very conscious that there's still 4% that is not yet menopausal. And my oldest pregnant patient is 54, still less than 55, right? Yeah. Not me, obviously. And estrogen containing method, you can continue if you don't have cardiovascular risk factor. But we have discussed if you have cardiovascular risk factor, don't use estrogen. Okay, so the same way, 50 and watch, and by 55, stop it. Okay. Okay, so now it's a quiz with no prize. Patient 1, 45-year-old, period 5, 6 weeks postpartum. Below 6 weeks, do not use CAC. Okay. Lean. Does not smoke, no diabetes, no hypertension. Sister is being treated for breast cancer. So is sister being treated for breast cancer a contraindication to hormonal contraceptive? Cute, thank you, that's good. So what would be the best contraceptive? Because she's 45, but she has no other risk. But over 40, cardiovascular risk increase at the baseline, venous disease increase at the baseline, but no other issue. So can she use anything? Is anything really category 3 and 4 for her? Seemingly no. Okay, so you have a more options for discussion, but you may want to caution her over the use of combined contraceptive. Okay. Patient 2, 45, parent 4, no wish for more children, obese, 20 cigarette, remember that magic number of 15, that does not mean anything. Hypertensive, vasomotor symptom. So does she has cardiovascular risk, arterial risk, venous risk, but she has vasomotor symptom, and therefore you have to consider the use of hormonal. So which hormonal contraceptive? Progestogen only. Okay, pass. My job is done. Okay, so this is the take-home message. Okay, the older we are, we have a specific safety risk with combined. Okay. If you smoke, if you're obese, if you're diabetic, hypertensive, if you're thromboembolic tendencies, don't use hormonal, especially the combined. And if you're over 40, check about vasomotor symptom that may influence the use, because it doesn't make sense to use non-hormonal plus add on some hormones for the treatment. Okay, and non-hormonal methods, habis battery dah. Non-hormonal methods are safe regardless of age. Thank you very much.